Continuing the theme of autoimmune disease, we've now got Professor John Isaacs, who's Professor of Rheumatology in Newcastle, and Director of the Wilson Home Immunotherapy Centre, is that right? Who's going to talk us about, tell us how to flick the switch and switch off autoimmune disease. So thank you very much.
Thanks very much, David. Thanks for the invitation. A bit like Martin, I've had to condense about a 35-minute talk into a 20-minute talk, so you'll see highlights here of what I think about the future of autoimmune disease. Those of you who know me and have heard me talk before will know that I'm very interested in immune tolerance and the ability to switch off unwanted immune responses. So my talk's just broken into two sections, a very brief section at the beginning where I try to bring over to you the concept of therapeutic tolerance and what we mean by that. And then I'm going to talk a little bit about the strategies that are out there, not so much in the clinic, but in the experimental medicine centres and phase 1 centres. So let's talk a little bit about therapeutic tolerance. And when you think of your immune system, in you and I, in a healthy individual, your immune system is an extremely complex organ, billions and billions of different T cells and B cells of varying specificity, each able to recognise something different. And it's kind of grown up to recognise the outside world without recognising any of the inside world. And it's not magic. There's very complex processes that the immune system has to go through to achieve this state of perfect tolerance, but not surprisingly it sometimes goes wrong, and that's when we see autoimmune disease. And in my talk I sort of grew up in terms of my PhD in a transplantation laboratory, and my belief is that the immune mechanisms that underlie transplantation are pretty much the same as the immune mechanisms that underlie autoimmunity. It's just easier sometimes to explain the concepts in terms of transplantation. So I say that in this first slide I'm going to talk about skin grafts in mice, just to get the concept over. And what this is all about is, as you will realise, if you transplant a bit of skin from a white mouse onto a brown mouse, over the course of a couple of weeks that skin will get rejected. I mean, that's just a normal transplantation response. That's the immune system doing its normal job. It was discovered back in the 80s, just after monoclonal antibodies were discovered themselves, that if you treated that brown mouse with a variety of monoclonal antibodies, started off using just anti-CD4, some situations you'd combine it with the CD8, sometimes something completely different. But if you treated that mouse with monoclonal antibodies against the T cell, and during that period, which might just be 2 weeks, put the skin on, the white skin, although the antibodies only stay in the circulation for a week or two, that skin never gets rejected. So somehow those antibodies have educated the immune system to think of that white skin as self. Whereas a few months down the line, that mouse will still reject grey skin. So it's not immunosuppressed, it's specifically learnt to think that that white skin is self skin. And that's what we call therapeutic tolerance in its purest form. We understand now that if you look at these mice in detail, you could take spleen cells from this brown mouse that's been treated, and that contains what we now recognise as regulatory T cells. It's a very powerful system because if you transfer those spleen cells, that new brown mouse, without giving it any antibodies, will now accept white skin. So you've done something fundamental to the immune system of this mouse to tolerise it, and that's largely predicated by these regulatory T cells which you've induced, and that's a very specific re-education of the immune system, as we call it. So that's kind of where it all started for me. This was going on back in Cambridge in the sort of mid to late 80s. And it's probably important to say that in the early days, this sort of effect was achieved using what we call depletion antibodies, a bit like the mouse equivalent of Campath, if you like, alemtuzumab. But now we recognise that antibodies that don't kill cells are actually more powerful, and that's probably because they're better at inducing these regulatory T cells. So why does it work? And some of you will have seen this cartoon before. It's because we believe the T cell that we're targeting pretty much is the general of the immune system, and it tells the other cells in the immune system, the B cells, the cytotoxic T cells, the macrophages, it sends out signals and tells them what to do. So in the case of arthritis, it tells those cells to attack the joint and cause inflammation. So what we think we're doing with these antibodies is somehow, we call it blindfolding because we have so little knowledge of what we're doing, probably quite appropriate for an ophthalmological audience. We're blindfolding those cells. They can't interact with their neighbours for a finite period of time, and the system seems to default back to tolerance with the appearance of these sort of regulatory T cells or the immune system's policemen. It's all very theoretical, and there's a lot of work going on now trying to understand what's going on in these cells that we're targeting, because the problem, because we don't understand this, we have no biomarkers of the process. And I'm not going to go into that today, but it's one of the reasons it's been quite hard to translate these strategies into the clinic, because it might take 3 months for tolerance to develop, and without biomarkers we don't know that it's actually happening. So it's very hard, particularly in a disease like rheumatoid arthritis, to leave your patients untreated whilst you believe they're getting better, because if they don't, you've not done them any favours. So we desperately need to understand this process a bit better, and that is happening actually. So let's move straight. That's the concept anyway of what we're trying to do. Way back then, back in the late 80s, early 90s, I was just moving from a sort of laboratory scientist PhD to a clinician scientist postdoc, and we were starting to think about tolerance in the clinic. We can talk about 2 types of tolerance. In the ideal world, you'd like antigen-specific tolerance. So in a disease like rheumatoid, we'd like to know what the autoantigen is and just switch off the T cells that are causing joint damage. In the vast majority of autoimmune diseases, we don't know what those T cells are even today. And so antigen-specific tolerance is still pretty difficult. In diseases like allergy, which aren't really autoimmune, but you could liken them to dysregulated immunity, it works, because we know that in somebody who's allergic to house dust mite or cat dander, we know what the antigen is, and effectively desensitization is achieving a form of, they call it immune deviation rather than tolerance, but they're re-educating the immune system to respond in a different way. Not so much luck so far in autoimmunity, and we're much better at developing strategies for what we call antigen non-specific tolerance, or as I've described it, re-educating the whole system. That's what I've just shown you. Those CD4 and CD8 antibodies treated the whole immune system, but for some reason it only seemed to have an effect on the sort of bad cells, if you like. And I'm just going to talk about human studies. Okay, so you've heard about CAMPATH. The reason I mention it here is because this was being developed in the lab I was working in back then in the 80s. As you've heard, it was the first so-called humanized antibody, and it killed not only T cells and B cells, but NK cells and monocytes. We kind of think of it as like a domestos antibody. It kills all known cells, actually. Before multiple sclerosis, we were using it to try and treat patients with very refractory rheumatoid, and this was before we had any of the anti-TNFs. We basically had gold and penicillamine and methotrexate, I think, in those days. None of them worked particularly well, at least at the doses that we were using. And a bit like Martin's story in multiple sclerosis, it was quite interesting because nobody believed that T cells were important in rheumatoid. We were really swimming against the current here. Everybody was starting to say TNF is the magic bullet. We said we think it's T cells, and when we gave a bit of CAMPATH, in fact our patients did pretty well for about 6 months. The downwards is good here. This is tender joints and swollen joints. Then the disease would kind of flare a bit, and then we could give another course and they'd get better again. So we didn't have, some patients, a bit like Martin, seemed to have very long-term responses, but on the whole we saw modest, even so, medium-term benefits, and this was really refractory patients, so this was quite remarkable. These patients were getting better within about 24 hours. But there were downsides, so we saw what we called cytokine storms, which weren't like, they were like a mini Northwick Park scenario. Patients got fevers and rigors. They didn't get renal failure. But I do remember in those days we used to, there used to be a thing on the rheumatology ward that you always knew which patient was getting CAMPATH, because when you walked on the ward you could hear the bed rattling, because in those days we had these metal beds and the patient would have rigors and you literally could hear the bed rattling from the end of the ward. It would last about an hour and then it would wear off again, and then the patient would wake up the next day feeling a lot better, so it was justified. That itself wasn't a problem, but this long-term lymphopenia, the immune system didn't really reconstitute very well in patients with rheumatoid, and that was more of a worry, because of course back in the 80s we were worried about diseases like HIV, we still are, but we didn't know that we weren't inducing an HIV-like syndrome. I still follow these patients, and actually so 20 years later they haven't developed HIV, even though they still have very low numbers of lymphocytes, so they're kind of an interesting cohort. We treated about 50-odd patients in those days. I won't go through the multiple sclerosis because you've heard that, but it works in multiple sclerosis, and they don't have the reconstitution problems, except when they reconstitute they get this secondary autoimmunity, which is a problem in itself. And I know Alastair Coles down in Cambridge is now experimenting with thymic stimulants at the same time as giving CAMPATH to try and ameliorate those problems. So what other antibodies are there out there? There's lots of them, to be honest, and many of them are not doing great things. There's been lots of anti-CD4s. I'm quite interested in anti-CD3. So the anti-CD3 is present on all T cells. Some of you may have heard of OKT3, which has been used for refractory rejection of kidney grafts and liver grafts. It did a really great job of preventing rejection in patients that were refractory to steroids. Patients got very sick. That was an Northwick Park scenario. Some patients got shock lung, some got kidney failure. Occasional patients died with OKT3. So that risk was much too great for autoimmune diseases like rheumatoid. But we now understand quite a lot about those reactions, those sort of cytokine storms, and they're very much to do with this end of the antibody, so not the antigen binding end, it's what we call the FC part of the antibody. When this binds to the T cell, to the CD3 antigen, this binds to FC receptors on cells like monocytes and macrophages, and it's that interaction which triggers a cytokine storm. So what we did many years ago was take an anti-CD3 antibody and mutate this residue here at 297 from asparagine to alanine. The reason we did that is because this is the residue to which this purple sugar attaches, and we knew that sugar was important for FC receptor binding. So if you could create an antibody that doesn't have sugar here, then it shouldn't bind FC receptors, it shouldn't have the same side effects. And when this so-called Aglycosyl anti-CD3 was used in transplant recipients, indeed, it was effective in terms of preventing rejection, and the patients didn't have the cytokine storm that you would see with drugs like OKT3. We have used it in a few rheumatoid arthritis patients. This was about 12 years ago in Leeds, and surprisingly, they still got a bit of a cytokine storm, and 10 years later, we still haven't quite worked that out, but it seems a bit more toxic in rheumatoid, and so we're still paused on that one. It has, however, worked very well in diabetes, and it's probably worth saying that with this antibody, at least in mice, we understand a little bit about how it works. So if you take mice with diabetes and give them one of these anti-CD3 antibodies, the T cells that are actually destroying the pancreas seem to die, so you get rid of the bad cells, and then you do see these regulatory T cells flood into the pancreas and somehow keep the thing under control. So it seems to do in mice what you'd like it to do. In a phase 2A study in diabetes, you may have seen this, was published 2005, very early disease, so these are patients who have only had insulin treatment for less than 4 weeks, young diabetics. They received 6 daily infusions of anti-CD3, again trying to achieve this switching off the disease. This is baseline. In green are placebo patients, blue are patients that got the anti-CD3, and this was their insulin requirement at baseline. After 6 days of treatment, nothing else, 18 months later, this is the insulin requirement of placebo patients, so as you can see it's increased reasonably, whereas the placebo patients, the active treatment patients, if anything, required less insulin than they did at baseline. So for 18 months their disease has paused. And if you look at this in a different way, again, the treatment is red, placebo in blue. The HbA1c, the control, is just as good as in both groups, but the insulin requirement in placebo has slowly gone up. After 4 years now, the anti-CD3 group has just about got back to baseline. So it's not cured the disease, but it's certainly had a long-term effect. And I guess the hope is that you could give this perhaps every 18 months or once every 2 years. The bad news here is that this drug failed in phase 3. I very much believe it's because this was pre-Northwick Park, the phase 3 was post-Northwick Park, and they brought the dose down almost to what I thought at the time were homeopathic doses, and I think the data proved it. It just did nothing at you're talking of 0.1 milligrams per patient. It's ridiculously low doses, so company went bust, although this drug's now owned by GSK and they're going back into diabetes, so it's not dead yet. But there were some important lessons there. Okay, so there are other antibodies out there, but I think anti-CD3 is very interesting. I'm going to move now on to cellular therapies, because in many ways these are an attraction. They're more sophisticated, they're more complicated, but as I'll show you, not necessarily. I largely moved into cellular therapies because when I moved to Newcastle to open this Wilson Hall Immunotherapy Centre, in those days I could collaborate with Herman Waldman and Jeff Hale, who were down in Oxford. They could make antibodies in their Sterile facility, these were safe antibodies and we could put them into patients. Then when the European Directive on Clinical Trials came in the early 2000s, it basically scuppered any of that sort of work because we couldn't afford to do all the preclinical animal toxicology that became necessary. So we had to stop using these experimental antibodies, whereas cells weren't regulated in quite the same way. So I moved into cellular therapies largely because the regulations pushed me down that route. But it's interesting, essentially, rather than putting the antibodies into patients and trying to get the cells to change character, we're doing the same things out of the patient to the cells. So in some ways we were learning a little bit more. Going back to this figure, what we started off doing now was looking at dendritic cells. So the cell I haven't shown you on here is a dendritic cell, which tells the T cell what to do. And what we've tried to create is a so-called tolerogenic dendritic cell, to achieve the same as the antibodies. So a dendritic cell that rather than switches on the immune system, switches it off. And actually, there are lots of ways to do that. I'm not going to go through this in detail for obvious reason. There's lots on here. The reason dendritic cells are nice is because they're quite easy to grow. You make them from peripheral blood monocytes in the lab. They take about a week. If you want to make a normal dendritic cell, you use 2 cytokines, interleukin-4 and something called granulocyte macrophage colony stimulating factor. That's easy, takes 7 days, and you can do it in almost any cell biology lab. But if en route you use certain growth factors or cytokines, or you can do a little bit of genetic engineering, or as in our trial, you can use pharmacological mediators, you can transform that dendritic cell from one that stimulates the immune system to one that switches off the immune system. So in our hands, we use a simple combination of dexamethasone and vitamin D3. They both happen to inhibit a pathway called NF-kappa B in the cell, and that switches off. It converts a dendritic cell that would normally lead to gamma interferon production in T cells to one that leads to IL-10 production. So it down-regulates the immune response. We're one of the first groups in the world to be doing this. I'll show you there's 2 others now. And we're still in the middle of this proof of concept study. We're trying to treat 12 patients. We're about to treat number 6. And our concept, this is a safety study essentially at this stage. We're taking a patient with an inflamed knee down here. This is a rheumatoid patient. And at the moment we're leukapheresing the patient. We don't think this will be necessary ultimately. We think we'll be able to do this with a blood donation. But we're doing a leukapheresis to make sure we get enough monocytes. They go into the so-called good manufacturing practice laboratory. Anne Dickinson runs this in Newcastle. And through the process I've just described, after 7 days, those monocytes become tolerogenic dendritic cells. The reason we're looking for an inflamed knee is because we put these cells into the knee using an arthroscope so that we know we get them into the joint. Initially we did this for safety reasons. We thought, well, if they didn't work and in fact they caused a flare, we could just wash the joint out again. In actual fact, it's been quite a useful thing because we can now take synovial biopsies at the beginning and a couple of weeks later and look for biomarkers to show whether or not we've actually achieved anything. So this is very much proof of concept. I think the one thing I've learnt from this study so far is when you design this sort of protocol, try and make it simple. This has been a very tough protocol for all sorts of reasons. The patients don't mind going in for it, but actually there's only about 1 day a month where we can line everything up to do this in terms of leukapheresis, the arthroscopy at 0 days and 14 days, etc. It's proven a little bit trickier than I thought. The patients are happy, but it's taken a long time. There are 2 other groups in the world doing this sort of thing. So Jenny Thomas in Australia has actually done her phase 1 trial in rheumatoid, and they're using their cells under the skin, which to me has never quite made sense. But actually, at the end of the day, we hope these cells will go to the local lymph nodes, because that's where, if they're going to regulate the immune system, they'll be doing it in the lymph nodes rather than in the joint. So I guess if they go into the skin, they might still get to a lymph node. Whether it's the right one or not, I don't know. But that was also phase 1. It showed safety. We're waiting for the biomarker efficacy data coming out. And then this group in Pittsburgh is using the same approach in type 1 diabetes. So there's a couple of groups elsewhere in the world doing something similar here. Probably the most popular cell in terms of inducing tolerance is the so-called regulatory T cell. This was just being discovered probably in those early days of the antibodies 20 years ago. Now every lab in immunology lab in the world seems to be focused on regulatory T cells. They are the cells that seem to keep the immune system under control, and there's quite a lot of evidence that in various autoimmune diseases there's either insufficient numbers or they don't work very well. And even some of the genes that we find in the GWAS studies, the genome-wide association studies in rheumatoid, seem to be regulatory T cell genes. So it's not so that's the final answer, but not just in rheumatoid, various autoimmune diseases, there are clues to say these cells are defective. The problem with these cells compared with dendritic cells is they're much harder. You can't really make them very easily in the lab, and they don't have any unique markers, so to pull them out of a patient's quite hard. You can't separate out regulatory T cells without simultaneously taking out some activated T cells that are probably the ones that you don't want. So they're not quite so straightforward to isolate and to purify, but there are protocols out there. The other worry about them is that there's some evidence that they can transform back into bad T cells, so what we call Th17 and Th1. They don't seem quite stable enough. But having said all that, there are some labs around the world that seem to be managing this. They tend to be hematology labs for the reasons that you might expect, because they're good at this sort of thing, and the early trials are in graft versus host disease, and so these do seem to be safe. And to a certain extent, if you can say from a phase 1 study, they seem to be doing something in graft versus host disease. One nice thing about the regulatory T cells is that the dendritic cells I've just shown you, they have to come from the patient that you want to treat. So they're what we call a bespoke therapy, with all the obvious complications. You've got to have the facility locally, it takes a while. These regulatory T cells, they can come from the same patient, but there's quite a lot of evidence that you can use so-called allogeneic cells. You can get them from one individual and use them in another. So you can even get them from umbilical cord blood, for example, where there's lots of them. So it becomes an off-the-shelf therapy, and that's where the interest is developing. They're a little bit easier. You just freeze them down and use them when you want them, or you buy them from a commercial manufacturer. And I've seen a number of trials. As I said, there's a few published papers. I've seen trials that are ongoing in transplantation. It's kind of the flavour of the month in immunotherapy at the moment is these Tregs, but we'll see. I think the evidence will be in the eating, or whatever you say. One marker that we do know about is this CD20. These cells have a high expression of the so-called interleukin-2 receptor. They seem to respond to interleukin-2 particularly well. And this trial was published in the New England Journal 2011, and this was quite interesting because it's in between using an antibody and using cells, really. So this was a trial in patients with cryoglobulinemia, vasculitis, refractory, hadn't responded to rituximab or antivirals, and they actually gave cycles of interleukin-2. So the hypothesis is we can stimulate these regulatory T cells in the patient, we'll expand them. And what you can see here is every time they gave a course of interleukin-2, indeed the regulatory T cells went up. These are the CD4 ones in green, and there's also CD8 regulatory T cells here in purple. So actually quite a nice boosting effect on the Treg numbers. And if you look on this side of the graph, this shows the complement levels actually came up, and this shows that the cryoglobulin levels actually went down. And there's another figure in the paper showing that some of the symptomatology seemed to get better. It's always difficult with these early studies in a few patients. You only see the studies, obviously, that look good on the whole, but they always do look good. And I'm going to show you another one in a minute, which looks very good, and I never know how much to put into these studies. So this is the third sort of cell I'm going to talk about. This is what I call the magic cell, because it seems to do everything that you'd want it to do. And I don't think we've really got a handle on mesenchymal stem cells, but again, a lot of labs around the world are using them. They're immunomodulatory, so they're anti-inflammatory, they're anti-proliferative, they expand Tregs, apparently, and there's data to show this. They're also very good at tissue repair, so they secrete a lot of growth factors, TGF-beta, prostaglandins, etc., in indoleamine dioxygenase, VEGF. Again, these can be allogeneic, so they can be off-the-shelf cells, which makes them much more tangible in terms of a therapy. And again, you can get them from various sources. Umbilical cord blood, an interesting source is adipose tissue. So patients undergoing liposuction, there are companies that are harvesting mesenchymal stem cells out of the fat because there's lots of them in there. So, you know, these are interesting commercial possibilities. They just seem a little bit too good to be true, and I have to say, as do some of the data. So this is a paper published in Lupus, again 2011. It was a Chinese group, 15 patients, and all you need to know here is that up is bad and down is good, and this is one of these global, this is the SLE disease activity index, which is quite hard to budge in a refractory patient. And look at this, every patient seems to get better, every patient their proteinuria gets better, maybe apart from the odd one. You always say if something looks too good to be true, then it probably is, and this is this is an uncontrolled phase 1 protocol, but they tapered immunosuppression, they got the patients off steroids apparently, and they also showed their increased Tregs going around. So maybe it is true, but we all wait to see the randomized controlled trials of these sorts of therapies. That looks interesting. Finally, what's the real blunderbuss therapy? This a little bit goes back to Campath, but you may have heard of autologous stem cell transplantation, which we used in rheumatoid about 15 years ago. This is a bit like the Campath concept, which says that if you've got a bad immune system, can you use enough cytotoxic chemotherapy to get rid of that immune system and let a healthy one grow? So the concept here is you've got your patient with a bad autoimmune disease, you mobilize their stem cells using cyclophosphamide. This is a standard sort of hematological procedure. You leukapheresis them, which means you can harvest their stem cells from the peripheral blood, and you then get rid of the T cells, which we think are the bad cells, and freeze that batch of cells down for later use. At some time later, you myeloablate the patient with cyclophosphamide, irradiation, anti-thymocyte globulin, and you give them the stem cells back. So the idea is you're washing out their immune system and giving them a new one. So all sounds good. I was very cynical, I have to say, when this came out, because this was not long after I'd used the Campath, and I'd seen that it did quite a good job for a short period of time, but then the patients would relapse again. And the fact is, these are autoimmune patients, so when we say myeloablation, it's not like an allogeneic transplantation. You couldn't possibly give patients as much cyclophosphamide because there's a danger of death, and you can't risk that. So the patients, the doctors that were pioneering this were using sub-myeloablative cyclophosphamide, really, which means that there is autoreactivity left behind, almost certainly. You also can't get rid of all the last T cells in the graft, so you're probably putting some back in, and then surely you're going to regenerate autoreactivity from the patient's own immune system. The ideal here is to give an allotransplant from someone else, but again, that's too dangerous, graft versus host disease. So I was a bit cynical because I said, well, this is just a dangerous form of Campath. You will see problems. And in fact, in rheumatoid arthritis, it looked a bit like Campath. Patients got better for 6 months or so. And one thing I didn't say, they then responded a little bit better to the drugs they had failed before. So it looked like you were doing something to their immune system, but maybe debulking it rather than really manipulating it. But there are some diseases like juvenile arthritis where about half the patients seem to get better forever. It does seem to be curative in some conditions. And indeed, if you look at some of these patients with juvenile arthritis, this is a number of regulatory T cells in their blood. This is a healthy individual. This is a patient with JIA, so you can see they're a lot lower. And then after the transplant, they seem to come back up. And here in absolute numbers, they even overshoot. And this is, several years later. So here's a treatment. Maybe it's because the juvenile immune system is much more plastic than the adult immune system. It really can respond and produce Tregs and get back to normal. And I really finish with that slide because I think it gives us hope. I started off by talking about tolerance, and I said, well, we've got to get the right cells, and you've got to tolerize the antigen-specific T cells. I'm not sure that is true, to be honest. I think it's true in some situations, but we know that we all have aggressors. We all have autoreactive T cells. We could bleed anybody in this room and show that you have myelin-reactive cells, probably, or joint-reactive cells. It's just that you've also got lots of regulators. That's why regulatory T cells are so important. They keep the whole thing under control. And what we're beginning to realize is that in there's certain autoimmune diseases, not all of them, but many of them, it's just an imbalance. I say just, but a serious imbalance in favour of the aggressors. And it may be that using things like anti-CD3 or depleting therapies in younger adults or children, what we're really trying to do is just boost the regulatory side a bit and get things back in balance. And so I'm arguing much more these days that antigen non-specific therapies are sort of addressing this imbalance and just giving us the system a shove in the right direction. It won't always work because, of course, there is a genetic defect before you start. But there again, we know in rheumatoid that patients have autoantibodies for about 15 years before they get the disease. So you can have preclinical autoimmunity without patients getting sick. And I think this is the hope for drugs like anti-CD3, that we will be able to nudge the system in the right direction and get patients back in balance. Maybe not forever, but even if it's for a few years and you can do it again, that's sufficient. What we really need are the biomarkers to tell us that we're doing the job, because otherwise you just have to wait for the patient to get better and keep your fingers crossed. And if they don't, particularly a disease like rheumatoid, you're a little bit stuffed really, and so is the patient. It's a tricky situation. Very much the final word is all about timing. The other argument as to why these treatments have been difficult to get into the clinic is because once the patient's got autoimmune disease, their whole immune system really is pretty sick. We know in rheumatoid, as I just said, it takes 15 years to get from preclinical to clinical disease, during which the immune system is just getting sicker and sicker. But we can now identify patients if this is where the disease starts. We can identify them about 15 years before from their autoantibodies, and in some ways that's the diabetes trials I've showed you. They're identifying pre-patients and waiting till just the last minute when they get the disease to treat them. And so there's a really big window of opportunity, I think, here. We're not going to use treatments like stem cell transplantation in healthy individuals, but there's a lot of interest in oral tolerance induction, so we don't make immune responses to things that we ingest. Our gut immune system is very specialised to induce tolerance, so maybe we can reinduce tolerance that way. There's a lot of interest now in the bugs in our bowel, which shape our immune system, and there's some experiments suggesting that you can change your bowel flora and alter your immune responses, and that's a very exciting field. So there are kind of some safe things you could do very early if you know that someone's predisposed to autoimmunity, but the sorts of therapies that I've been talking about, you'd like to catch patients maybe in the year or so before they get clinical disease, or maybe when they just get imaging disease on ultrasound or MRI. So I think this is really important. When do we use the diseases? When they're safe enough, we'll use them very early. But just to conclude and summarise, antigen-specific and non-specific approaches are being developed for therapeutic tolerance induction. The specific approaches are at an earlier stage of development. The non-specific approaches I've told you about, non-activating CD3. I didn't mention co-stimulation blockade, but that's out there in the clinic. A number of cellular therapies are in development, and in severe cases we may be able to reset the immune system with a treatment like stem cell transplantation. So I'll leave it there. There's a few references if you're interested, so thank you very much.